And I'm going to minimize this, guys, so it's not in your way. And the way this works is that since I'm recording, I like to do a formal-ish introduction, but you all have this flyer. So you can know that even on the back side of this flyer, she doesn't know that part. I don't know if I sent it to her. I put a list of just the recent posts. That filled the page. I think that is all. Look at that. Just the last year. Check that one out.
There, or I have to
So you just come up here. Come on up here. Just the recent ones. But Dr. Kovner, I am so thrilled that she's here because I've been trying to get her for a while. We've had some of our students who have actually been excited to use her work. What I like, and I asked her to kind of focus on it, the multiple year study she's done on new graduates, on new nurses. And this is one of our graduate students who said she's hoping her dissertation will be in this area. Some of my other colleagues who work with our students at all levels, and I think knowing what they find out when they go to work, you'll hear Dr. Kovner speak about. So I'm going to give the microphone to her, which is simply saying it's your turn. Now what you can do is there, or you can just hit that space bar right there, or you can up and down, and you want to get it out of your way, you get it out of your way. All right, there you go, Dr. Chris Kovner.
It's a pleasure to be here. I've never been to Molloy College, and it's a very impressive campus. It's so nice to be at a place where there's lots of grass and trees. And this building is fabulous. I'm not going to talk a lot about methods, even though Patty's here. But you should feel free to ask me questions about methods as I go along. I'm talking today about a large project that was funded by the Robert Wood Johnson Foundation. Nancy Fishman was my program officer, and she was enormously helpful through this whole project. We had a National Advisory Committee. James Price, anybody heard of Price's intent to leave theory?
I know intent to leave.
Anyway, he died in the middle of the project. He didn't like us tweaking anything in his model, which is very interesting to me. And Diana Mason, Linda Everett, Kevin Kenwood at the time was at the National Council of State Boards of Nursing, and Brenda Cleary. We had a huge team. These are the people came and went on the project. We'd have a research assistant for a couple of years while he or she was a student, and then they'd leave and somebody else. So we didn't have all these people at the same time. And my colleague, Carol Brewer at University of Buffalo, was a co-I on this, and she had a whole team also. So remember back in 2008, for those of you who are old enough to know that, and we had all this talk about a nursing shortage. So the Robert Wood Johnson Foundation was very interested in that, and their board in particular had stories from families about not being enough nurses. They wanted to do something about it. There's also a lot of information about nurses leaving nursing. There seemed to be we thought there was a lot of confusion between nurses leaving a particular job and leaving nursing, and reports of very high turnover rates and huge costs. I want to put a little bit in context the Future of Nursing initiative. The IOM report in 2010, two of the messages were to expand the opportunities to lead, higher levels of education and training, increase the proportion of nurses with a bachelor's degree, and double the numbers of nurses with doctoral degrees. So part of what the foundation asked us to do was also inform that. Now, they asked us that in the middle of our project, and so we hadn't set up everything exactly to do that. And one of my advice is when you deal with foundations, in many ways it's different than dealing with the government with grant, because they have ideas. Sue Hassmiller in particular. We did surveys, I don't know, we did about 8 or 10 surveys. I have the details later. And before each survey, Sue Hassmiller would call and say, you know, I've really been thinking about this. Could you add a few questions on? And I would say, no, the survey's all really long. Well, it'd be really helpful if you could just add these questions. and so we would did. This is an overall on the main project. We did a panel survey. We surveyed the same nurses 6 times, and it is the only panel survey that I know of that has been done on nurses. The National Sample Survey, when that was done, picked a different group of nurses each time. We said to the foundation, not only would it be interesting to follow this group, but it'd be interesting to then do some cross sections of new cohorts. And so starting in 2009, we did a new cohort of new nurses. We did that again in 2012 and again in 2016. Kind of in the middle of all this, one of my colleagues was very interested in quality improvement. And so we talked to the foundation and said, you guys are interested in quality improvement. We are. Can you give us a little more money and we can do some surveying on quality improvement? And so we took our main sample from wave 1 and did a quality survey, and then took a new sample that was from our new cohort 1 and did the same survey so we could have some sense of change in that. We basically used people who were licensed between 2004 and 2005. We got lists of these, but there had been a big study done in Washington where they had constructed a nationally representative sample, and we used the same sampling that they did because we had visions of using some of their data. They were looking at health changes across America in different geographic areas. So we used the exact same areas. We had to get lists of nurses from 34 states and the District of Columbia. What is amazing to me is that each state, we live in this country with states, the way to get the lists are totally different. And they cost totally different amounts of money, and they take different amounts of time to get them. And New York was the worst. New York, even though Carol and I are both from New York, and Carol works at a state institution, refused to give us the addresses of the people in New York. They would give us, Susan Smith, Queens, New York. Now, there were many people. And so we said, so we would send letters and we'd get back, I'm not a nurse. We eventually went to the Board of Regents to see if we could convince them for the next sample that we were drawing, and they said no. But if you would like to invite people to a continuing education program where you at NYU, we'll be happy to give you the list. And so we thought about lying. There's a lot of decisions you have to make.
It's a stretch, but it's not.
Instead, we contracted with State University at Albany, who had the list because they could do certain kinds of analyses, and we paid them, and we had to send all the surveys there, and then we tried again as we were going, and then we just decided, too bad New York. You'd be really lucky to have all these data about New York, but you don't want it. That's okay. So this describes that. If you look at geographically what our main sample is, the sampled states are the gray states. It looks like North Dakota and that part of the country is a little underrepresented. We had this fancy sampling guy who worked with the sampling strategy that this other group had used, and he convinced us that we had a nationally representative sample, and so we said okay. Back then, the one-year organizational turnover rates were pretty high. One of the things that Linda Everett talked to us about was internal turnover, because people hadn't addressed that, and although that's not a problem for the organization, as we get more and more of these health systems, it becomes a great problem for the particular units. Okay, so now I'll give you some data. The number of nurses who left their first job within 8 years. Within 8 years. So at wave 1, 18% had left. At wave 2, 31% had left. And at wave 5, which was 8 years later, about 60% had left. So what had been circulating in the nursing literature is, oh my God, all these people are leaving nursing. What we found was they're not leaving nursing. Very few of them are leaving nursing. They're just going somewhere else. And most of the studies that have been done on nurse turnover have been done at the organizational level, where NYU might keep track, or they do keep track, of their turnover rate, or a bunch of hospitals would be asked by the hospital association what their turnover rates were. Ours was the first study where we did it at the nurse level, and so it didn't matter whether they stayed at the organization, whether they left the organization. If they were still working as a nurse, they weren't leaving nursing. And so that was one of our most important early findings. I'm just going to give you some highlights of different analyses that we used. One that the foundation, of course, was extremely happy about was that baccalaureate graduates' turnover rates were lower than associate degree. This is one of those statistically significant. Is it really meaningful? A 2% change or 1% change after 2 years. But what was important is there have been a lot of literature saying that the baccalaureate nurses in particular were leaving hospitals. We were paying all this money to educate them, and then they left the hospital, and they weren't taking care of patients anymore. They were working in the community in some job. My background is community health, so I was actually happy to hear that. But anyway, the people in our world of baccalaureate programs were also happy to do this. From a theoretical point of view, we decided to test a model based on Price's work, and we made some tweaks to his model, which, as I said earlier, wasn't loving, but we were in charge, and then he wasn't with us anymore. And so this is basically what the model looked like. And over the years, we did a lot of descriptive stuff, and then we did model testing. So in terms of model testing, as I said before, nurses leave organizations not nursing, and the reasons that they leave organizations are low organizational commitment, not surprising, low satisfaction, high intent to leave. Historically in the data, a lot of people, when they studied turnover, in fact studied intent to leave rather than actually leaving. And because we had this longitudinal study, we were able to look at actual leaving, and there's, not surprising, a high correlation of intent to leave with actually leaving. High injuries, again, I don't think that's a surprising finding, knowing what we know about back injuries. And if the nurses perceived poor management, they were much likely to leave the organization. We found that consistently in all the various ways that we asked that question, that the major reason that nurses leave organizations is because of poor management. And that's probably, again, not a surprising finding for people in this room, but I don't know, I can't remember the number, but 75% of nurse managers have had no education or training in how to be a manager. And the skills that one needs to be a manager are actually quite different than the skills one needs to be a good nurse. And it's not uncommon at my hospital for the great clinicians to get promoted, because then they're a resource to the nurses on the floor, and you can go say, oh, my patient has this problem, and the person will know the answer to that. And what places like NYU and others do, not uncommon, is to give them on-the-job training of some sort, which is often given by the people who already work there, who are using the same management styles that they've done for X number of years. So we think that was a very important anybody in the room, nurse manager who I've offended?
I have a question about this. It looks to me, accepting high injuries, it looks to me like those factors would all load very heavily on each other. If you got a crummy manager, you're going to have a high intent to leave and you're going to have low satisfaction and not too much organization. It looks like they really are.
They're very,
Yeah.
they are. We, one of the other things we think that's important about our work is if you look in the nursing literature about articles about turnover, it's not uncommon, particularly years ago, to see the study is satisfaction related to turnover and is, I don't know, injuries related to turnover, and to find significant relationships. Part of that happens because we think, because there's an, if you have a underspecified model, you get all kinds of relationships that are not necessarily, I don't know if the word is accurate or accurately reflect what the real world is. And one of our strengths was we had a very fully specified model. And we could do that because we had a very large sample. And we also had on our team a great econometrician named Bill Green. He wrote the kind of econometric textbook that people use. And my daughter, this is an aside story, my daughter at the time we were in the middle of all this was getting her Ph.D. In economics at Harvard. And I told her, you know, Bill Green, he works with me. And she said that she said she was at some, I think it was a dinner group of women in economics in the kind of Boston area. And she told the women that my co-investigator was Bill Green. And they were like, oh, your mother knows Bill Green. That's so amazing. And I did tell Brewer that. He was very happy. He's at our business school, and the business school liked him working with us because it could show them that they had do-gooders on their faculty. And for one of our first studies, when you would go to the business school homepage, there was a little thing about our study. And of course, our dean was very happy about that. And their dean liked it because people would think that they didn't just study about how to make more money, but they were studying how to do good for society and help everybody have more nurses. Yes.
I'm sorry. The poor management, is that defined or is that perceptive?
Everything, all of our findings are based on the nurse's perception of what was happening. We use scales because for most things.
But it was not defined in terms of education, preparation.
No.
So that could
it was
overlap a little.
So it was asking the nurse a bunch of questions about their managers. No, so we didn't objectively measure any of this. I mean, objectively, I don't know if there is any objective anything. Anyway, okay, so what impacts organizational commitment and satisfaction? We found positive autonomy, so the perception that the nurse feels autonomous and can make decisions on her own. We also looked at whether the organization was a magnet hospital, because we wondered, you know, how much that meant.
Sue Hasmiller. Sue Hasmiller question, right?
Well, anyway, we thought that was important. So in the first survey that we did, like 25% of the nurses said they worked in magnet hospitals. So Susan, I can't remember her name, she was at our hospital. She was a magnet visitor. And so I said, you know, is this possible? You know, does this mean our sample is like really bad? Because we got all the baccalaureate nurses who work at magnet hospitals to answer our survey. She said that's a bad number, something's wrong. So what we did is we looked at all the we didn't ask them what hospital they worked at, because we really wanted them to think that they, you know, there's no way this could be connected with their jobs. We did ask them the zip code where they worked, and we knew that whether they worked in home care or hospital or whatever. And so we did a crosstab on whether, knowing what their zip code was, that they said the zip code of where they worked was. And we had a list of where all the magnet hospitals were. And a huge percentage of them, there was no magnet hospital where they said they worked. And so usually when we did our analyses, rather than doing whether the nurse said that she worked at a magnet hospital, we did use the people who said they worked at a magnet hospital, and there was a magnet hospital in the geographic area where they said they worked. So I brought this up to Peter Beerhouse. He was doing some presentation that I went to, and I love Peter, and I think he does great work. And so he was talking about magnet hospitals, and I asked him, did he adjust for anything like this? And he said no. What it made me realize is there's so much misinformation. If you really get down to the nitty-gritty of what goes on in research, all kinds of decisions are made. Now, one of the other advantages of what we did is if it became clear that a question that we asked at wave 1 wasn't a good question because we could figure it out from answers and stuff, we could re-ask it at wave 2. And so that was very useful for checking the validity of our data. All right, what works with organizational commitment and satisfaction? I said autonomy, promotional opportunity. That makes sense with organizational commitment, because if you're ready to move on and there's no positions for you, you're a great clinician and you want to be a nurse manager and you don't want to go back to school, then you might leave the place. Supervisor support. Now that's different from their perceptions of nurse management. This was a scale, a multi-item scale that we have good reliability and validity. First of all, we picked mostly scales that had been used many times before, and we did validity and reliability checks on every one of our samples. Anyway, so that supervisory support, variety, procedural justice. And procedural justice is a sort of concept like fairness, that there's no sort of favoritism in anything. RN, MD relationships and work group cohesion, the whole idea that if you're a group and this is where your friends are, you're reluctant to leave because then you won't get to see them every day. I don't think these are surprising findings, but I think they're useful in that they validate much of what we probably would have said if I'd asked any of you, what do you think things are? Negatively impacting organizational commitment was organizational constraints. That was particularly troubling to us. That was a scale that had questions like, how many days a week do you not have the supplies that, or how many, once a month, once a week. Extraordinarily high numbers. Like for most of them, 2 days a week, they didn't have whatever it is they needed to do. And I said, if I'm a professor at NYU, and if I didn't have a computer, I couldn't afford it myself, and my job didn't provide it. How can you do your job? And I suspect, I don't know, but I suspect the big companies like Alcoa and IBM and General Motors give people the supplies they need to do whatever it is they need to do. Mandatory overtime, patient load, and quantitative workload, by the way, only affects satisfaction, if you see the little asterisk there. Local and non-local job opportunities. So I think if people are so satisfied, but there's no other good place to work in town. I think we're spoiled, people in this room, because there's so many different opportunities for where people can work and where your graduates can work. But in much of the country, that's not true. And more hospitals are combining in towns like Binghamton, New York, or whatever, Wisconsin, La Crosse, Wisconsin. And so there is only one choice. Okay. We asked the question of these in our first survey. How long did you plan to stay when you took your first job? And you can look on the right. These are our various samples. Less than a year or two, 80% or 75% said they didn't plan to stay there very long. So that suggests maybe there's not a lot an organization can do to keep people. I give a talk in the last semester undergraduate course. And, I say, how many people plan to work in a hospital? And, the whole class. There's 5 people in a class of 120 who say, I'm going to work in home care, or rarely does anybody say nursing home or ambulatory care. And then I say, did your professors say that you had to work for a year in a hospital? Oh yes, everybody's said that. And then I say, I never did that. I actually, my first job out of school was working for the city health department, when the New York City Health Department was a fabulous place to work. I did work for a year as a discharge coordinator in a hospital, but I wasn't a staff nurse in the hospital. And so they're all amazed by that I actually am alive and well and spent a year in the hospital. And so then afterwards, there's always a couple come up to me and say, well, you really think I can do that? You really think I can go right in home care? And I say, I can. But it's clear that that's the message. I assume I'm the only one at NYU who gives them a different message. Probably here, most of your faculty say, well, good idea, work for a year. But they only plan to work there for a year or two. And maybe they plan to work at NYU for a year or two, but they live in Manhasset. And so as soon as they got that 2 years in at the big medical center, then they can work at Syosset Hospital and be totally happy. And that's what they plan to do. Or they get married and they move to Binghamton. My sister-in-law is from Binghamton. That's one of my upstate go-to cities. So we have some recommendations about recruitment and retention. We also did some work on geographic mobility. And an amazing number of nurses go to school and work within 5 miles or 10 miles of where they went to high school. So we got data on where they went to high school and the zip codes of all that stuff. I think one possible flaw in some of our work is it may be that people don't know the zip code of their high school and don't know the zip code of the hospital that they work in. So take that with a little grain of salt. But we looked and we compared the mobility. I think I have another slide on mobility. But we looked at the mobility that the nurses had in terms of where they took jobs. And we compared that to other predominantly women occupations in the United States. We had census data. And only teachers had less job mobility than nurses. And economists, my daughter, the economist, those people dispersed all over the country. And thankfully for me, my daughter lives a mile from where I live, or a mile and a half from where I live. And yesterday her son started in the same high school that she went to. And in New York City, that's a big deal because there's so many different high schools. Anyway, that's another little aside. I don't remember what this is. So I'll just go. All right, so here's some other kind of highlighted data. We compared the different cohorts. Remember in the beginning, I said that we had 4 different cohorts, and we were looking at what changes there were. And this is a part that relates to the IOM report. A big finding that we had, we think, is the percentage of new graduates who are enrolled in a formal education program. So back in 2005, in the new graduates in their first, because of how we sampled, they could have graduated any time within the previous 15 months. And 11% of them were enrolled in some kind of education program, and by 2016, it was 23%. A lot of that was people just enrolling in baccalaureate programs. The other kind of interesting finding was that the percent of nurses who were enrolled in graduate programs early in the 2005 group and even up to 2007 or so, they were enrolled in master's programs. But what we saw happening in 2016 is the percentage enrolled in master's programs had gone way down, and the percentage enrolled in doctoral programs had gone way up, and we attribute that to the DNP programs. If you look here at the third, no bullet, but the bullet-like line, 3% in 2005 planned to enroll in a doctoral program, and 20% in 2006. And we don't think that those people are enrolling in PhD
We're not
programs.
seeing it.
At least we still have both programs. Do you have both programs?
Mhm.
And are you going to move to just having the DNP?
Never.
You know what you think. Probably not. I'm not in the in-crowd making those decisions at NYU, but I've heard no movement in faculty meetings or curriculum meetings for anybody saying, let's close the master's program. So we have both programs. We asked for the last group, the 2016 group, about debt. That was a Sue Hassmiller request. And 37% have debt of $25,000 or more. And that seems like a lot of money. That, to start out, if you're 23 and you're starting your life, have to worry about that. Oh, okay. Nursing degrees. What is this?
Oh, yeah, you can
Yeah,
close it. See the little
yeah.
X on the top of that? If you want to find that
So I
little
can
thing,
see
just
the
close the
actual
little X
title?
on the top of it. Yeah, just close it
Okay.
down.
So what you can see here is the percent of people whose first nursing degree was an associate degree. Can you see when I do the little arrow?
Yep.
Oh, you can.
It's a
Oh,
wonderful
okay.
room, yeah. All you have to do
Very
is look
good.
there.
Okay, so you can see that it was above 60%. Do you have an associate degree program?
No.
And it's a dramatic decline. And the percent of people with a BS or higher is dramatically up. Another aside story, we were getting ready for accreditation and we had to fill out, do any people know Barbara Kranovich Miller? Some people may know
I
her.
do.
Anyway, she's totally obsessive compulsive, and we had to do our CVs exactly this
We're
way.
the same.
And
Yeah, it's
anyway,
part of the
so
job.
we were doing them, and she came to me and she said, your bachelor's degree is wrong. You don't have a BSN. I said, really? I said,
State dings us
I went
on
to
that.
Columbia, and I know I have a BSN. Oh, no, you're wrong. Go look at the diploma. And, of course, Barbara's right.
Yeah.
New York State doesn't have BSN.
And they're the ones that come in and just as an FYI, if your CV is on file, and it's masters as well, you get discredits on the review if your CVs aren't correct. And the question
Ours
is
are
usually,
correct.
don't you even know what degree you have? And it's like, I don't know.
That's what Barbara, that's what she was saying to me. How can you be so stupid that you don't have you have the diploma hanging on the wall of your office for 30 years. Did you ever look at it? We tend in our writing to say BSN just because if you BS in nursing is a longer title. But
well, I got the NYU statement though then, and I tell my students PhD lower C is not an official credential.
right.
So we get told that one too.
We're pretty
Strict on that one. Yeah.
Well, Is this my
There's a
last
little
slide?
X at the top of that guy too, if you want to shut that little blinky thing off.
No, I
Oh,
want to
you're
get
not
to my
seeing it?
next slide.
Okay, okay, just click on it.
Just click on,
Oh, you can do your down arrow.
I did, it didn't work.
Try again. Trust me.
Ah, okay, I didn't do it hard enough. Another question that we tried to answer is, how can you predict who's going to become an advanced practice nurse? Our undergraduates, a huge percentage of them want to be advanced practice nurses. They know that walking, first of all, I'd say 80% of our undergraduate students are second degree. And particularly in that group, they want to become advanced. Now, they don't all follow through, but they do. Likely to start with a BS in nursing. I mean, that's kind of like younger, less likely to be married, enrolled in an education program right after they get out they get licensed. That seems to be true for our students. We have a scale about how important work is to you, and you want to get ahead, and they're more likely to say yes. That they earn national certification, and that they're more likely to be second degree. That raises all the issues that happen when hospitals are so powerful, and they say to government people who fund things, if you fund that, they're just going to be advanced practice nurses, and they're never, they're not. Nobody will be there to take care of the people in the hospital. I think we all know that world is changing. And we actually need a lot of people to take care of people who are not in the hospital. So it's not bothersome to me, but it's still, the hospitals are, particularly in New York, the hospital associations, incredibly powerful. And my experience with Senator Schumer is that what the hospital association says they want, the hospital association gets, unless the Republicans block something. And Senator Gillibrand does whatever Senator Schumer says to do. And I like Senator Schumer. Another issue that people were talking about is this interprofessional team education. We asked a couple of questions about it. We're not sure they're very good questions because we asked basically what they have, but we didn't do any kind of detailed questioning about, tell us more about the class. And the belief we have at NYU is taking statistics with people from the medical school or the dental school is not interprofessional education. I mean, interprofessional education is really about having a course where everybody's committed to that happening. We do have one required course like that with our medical students. It's a totally online course. We don't have much online. We tried to do that in person, and it's just really complicated with the medical school schedule and our school schedule because, of course, why would they be on the same schedule at the same university? So I don't think this is a very good question. I think this is an area that needs a lot more exploring for people who haven't decided what they're going to devote their life to. I think it's important, and we did not do a very good job on this. I have to admit that. We have some recommendations for having people can see you.
There's a little X on the top corner of that if you want to click on that. See that little X?
Yeah.
Get that one up there.
Sort of
Shut that
flashing
off. Yeah.
Okay.
It's gone.
I think that's better for everybody.
Yeah.
We have to make returning to school less expensive and more efficient in some ways. Do you have a lot of online courses?
Very little.
Yeah.
Well, our master's program has become, and we do hybrid. We don't do completely online at this point. The intent is still to keep Molloy what Molloy is, and that's an amazing face-to-face ratios. And as small as we are physically, we have an amazing reputation of being personal, and people know people's names. That's one of the fortes of Molloy. Yeah.
Schedule courses at times and in places that are convenient.
It's always hard.
All of our master's classes are, virtually all of them, are after 5 o'clock. So we do that. And I'm a big believer in increasing scholarships and financial incentives, so that people can just, if they could just work part-time, and we could figure out how to make sure they got health benefits for working. Our hospital's quite good at that. I can't remember. I think if you work more than 20 hours a week, you get health benefits. But I don't think that's a common approach. A lot of people come to work at NYU Medical Center because we have a very good tuition deal, and you don't even have to Did you do that?
Did it.
You did, and you worked at the hospital.
Yeah, did it in the beginning, and then we were. It was a long time ago, but they had funding at the time for traineeships, so maximize that.
I had a traineeship, and lived in poverty. Our master students. Oh, I can't take the midterm because I'm going to the Bahamas. Well, you knew that this class had a midterm. And you knew that it said the 7th week. Oh, I didn't really realize it. I didn't see the syllabus. We'd already bought the ticket.
Please.
I don't know. When I was a master's student, it seemed olden time. I did not go on any vacations. I mean, I didn't. It just wasn't, and I didn't buy a lot of new clothes. But it is what it is, and I am very ambivalent when the student comes and tells me that, it's good to do makeup exam. Whatever. Okay. I'm pressing.
Oh, click in the middle of the slide with the pointer, because you moved up that, and then click down.
Okay, race. One of the concerns I think we all have in the United States about nurses is that the percentage of nurses who are of the various racial and ethnic backgrounds does not reflect the population. Actually, New York State does very well on that. But if you look across the country, they don't. And you can see that over time, this is 2006, and that's when we surveyed them. They were the 0405 group. And the percentage of white non-Hispanics has gone down a little, significantly, but it's gone down. And primarily that has happened because the white Hispanics have gone up. And I think that's good. I think our biggest problem, at least in New York City, is a very large underrepresentation of people who identify as some Hispanic. Black has kind of stayed the same, Asian's gone up tiny, and there's a lot of people who do other, and we don't know what their background is.
It's really hard to get that data too now because there's so many social pressures on how you ask it, the way you ask it, the form you ask it, and whether or not it's standard. And then people have a visceral reaction to being asked. So, I try to hopefully enlighten people that answer it at your choice, but answer so we have some way of recording that.
We look to the U.S. Census. We study this a lot, and we do whatever the U.S. Census's decision. And I don't know what they're going to do in 2020. They're trying to figure it out. But what I've noticed is more and more people answering do not want to answer and other. And people have a right to do that. We have the same thing about sex. And I run a pre- and postdoc fellowship program connected with our medical school, and I was just looking at some applications. I was really surprised the number of people who just, won't answer those questions. Anyway, more males are entering nursing, so I think that's pretty good. That's gone up.
10%.
So we like that. And this gray blends in with the background. The other thing that's happening is where the people are working. So if you look at the new graduates back here in 04, 05, and 07, 08, it was hospitals. And if you look here, you can see it's gone up to outpatient. Now, what we don't know is the big recession happened right in here. So we have some evidence from our data that people who were working in hospitals increased the amount of time that they were working. So a lot of people went from part-time to full-time. Or we asked questions about how many hours a week did you work. And we think that is possibly because a partner lost his or her job, or they were just nervous. Their retirement account had gone down. So I don't know what's going to happen down the road. What that meant was associate degree grads were having a lot harder time getting a job in a hospital. And so we think that's part of it. I, as a public health nurse, would like to believe it's a trend. It has nothing to do with the recession, but I don't know. And my daughter, the economist, is totally unhelpful in that. Some good news. This is a pretty decent size increase in collegial RN MD relationships over the 10 years. Job satisfaction didn't seem to change at all, but I think it's positive. At least those relationships aren't getting worse. Quality and safety preparation was really not very good in 04-05. And baccalaureate graduates were much better prepared in all the quality improvement kind of skills. Let's see. So they're reporting a little better down the road. This is good for those of us who have baccalaureate programs, that the BSN grads report better preparation in evidence-based practice. I know we're really stressing that basically our undergraduate research course has turned into an evidence-based practice kind of course, so we like that. And no evidence that staffing was correlated with higher QI participation. Okay, verbal abuse and other kinds of injuries. We were really surprised at how high these numbers were. And we think we measured that quite accurately because we knew how many months they'd been working at their job, and we asked them in their current job so that they could focus on that, and then we adjusted, to a yearly rate. Verbal abuse at 62% is really abysmal. Now that's one episode at least, and we didn't give a definition of what verbal abuse was. I think this is another area that we need to learn a lot more about. One of my doctoral students has looked at this in depth, and he told me yesterday that he's going to be submitting a manuscript soon. Never know exactly what that means. And so how long before it gets out anywhere. But I think it's still a problem, and I think we have to do something about it. And so the first year we asked this, we said verbal abuse from colleagues. I don't really say colleagues, verbal abuse on the job. And so when we were reporting some of the findings, somebody said at a meeting like this, well, was that from family or from professionals? And of course we said, we didn't think about that. We just asked that. So then the next year, we did. We asked from family and from colleagues. And then the next year, we asked a little more in depth, and we separated nurse colleagues from physician colleagues. And a lot of it's coming from nurse colleagues, which is also a lot from patients. Basically what they said when we did it the second way is about half of it was coming from patients. I've had family members in the hospital. Some might argue that I was a bully at times, and I just think we just have to work with the students and help them deal with it better, because I don't know that we're going to be able to change the families.
In acute care psychiatry, more than 80% of the patients, and this is international and national, more than 80% of nurses have been physically assaulted by patients, and 46% have been injured enough to need more than one treatment. So, I mean, it's huge
That's
in
a
acute care
huge
psychiatry.
problem.
Huge.
Physician verbal abuse decreases with if there's higher physician abuse, nurses are less likely to stay on their jobs. I don't think that's a surprising finding, but if you're trying to convince an organization to do something about the abuse and have whatever kind of training they can have, this is one of those factoids that you can do. Remember I talked about before of their ability to difficult or impossible to do their jobs. It's a little scary that 17% say because of their supervisor. So questions like this is where we put it together and kind of say there's a problem with the nurse managers. It's a little of this and a little of that. Inadequate supplies, well, I talked about that before. I should move a little faster. I have a lot of information. I told you before about people geographically immobile. We have a nice paper on that. This slide points out that around the time of the recession and right after, they perceived fewer job opportunities. Originally, we talked about using unemployment rates. It doesn't exist anywhere that we could find an unemployment rate for health professionals, even let alone nurses. So, we thought about, well, maybe you could just use the general unemployment rate. And then we decided that, and we did that in some analyses, but we decided that the nurse's perception is really all that matters. Because if they think there's not a job out there, that's going to impact them staying at their job or not. So that was our way of getting around not having a real rate on that. Okay, this is some of what we did. This is a little braggy.
Go for it.
Yeah, go for it. We did this slide because we had to do a presentation at the Johnson Foundation.
It's awesome.
And so we wanted them to think they were getting their money's worth. They did say that the person above Sue Haskell said to us once, you guys are just the gift that keeps on giving. We did write a lot of papers. But, and that's partly a function of where Carol and I were working. This is just on the left is Carol. For those people who don't know her, in the middle is Amy Basaki, who's one of our junior faculty who studies sleep-wake issues and has used our data to study that. And on the right is Meyers, who is she's probably in her 5th or 6th year with us now, who was a co-investigator on the project. And
do a pitch for Academy Health too. It's an organization that we don't always think of. It's an incredible organization. It is interdisciplinary. The meetings are attended by thousands of physicians and economists and policymakers. So
and
it's
the
worth
day
looking
before
into.
the meeting, the nurses group meets. And so I think Amy's now on the board of that. Now, what's noticeable is that I'm not in the picture because I didn't go to Academy Health for that, but they all went, so that was good. These are some references, and this is how to get in touch with me. Let's have a talk
Leave that
about
one
what
up.
you think.
Sure. Thank you very much. If you want to take a seat over here and sit down and chat, that's what we can do for now. And we'll leave this open. I can make it available for other folks outside as well. But why don't you guys talk amongst yourselves?
I brought a copy with no pictures that you can give to people. We have a whole issue about copyright and photos.
Absolutely.
So
I'll put that on before we leave. If you want it, you can get a copy of these the slides with the information. I know a couple of people who are going to be doing the kind of work on workforce or on satisfaction or on why people leave nursing. And so questions open to Dr. Kovner's study or anything else?
Oh, just one more comment. One of the things we did was develop a file of photos that we had permission to use and photos that we didn't have permission to use, and there's NYU photos that only NYU people can
Can't even
use.
get a logo. I was trying to get a logo for the fire event, for the New York Academy of Medicine event. You can't get a usable NYU logo, you know, the torch or anything. You can't find that online.
I think they do that on purpose.
Yeah, it's intentional. So, but it's
And they change
understandable.
it every,
It's intense. It's
you know, and then we
understandable.
get these memos, you must use blah, blah, blah,
Yeah.
which I didn't do.
We do too.
Uh-huh.
So, open to questions.
I'm just curious, did you, in your survey, did you ask any questions about why they originally went into nursing?
We did not. And I think that's a whole area that needs to be explored. And I'm sorry that we didn't.
I teach fundamentals on first. I always say, why are you here? What do you want to do? And I would say 90% of my class usually says to be a nurse practitioner. So I'm just curious because I think somewhat from the sense I'm getting from the students and even when I go out in clinical areas that a baccalaureate nurse is kind of low man on the pole and they start to feel disrespected, not just by physicians, but on all levels, you know. And I got that sense from things they just threw out saying, you know, well, I want to be better than a nurse. I want to become more educated. And I said, what do you mean by more educated? Getting a degree or becoming more clinically competent, becoming certified? So it was an interesting conversation because first day of class, fundamentals of nursing, they already have decided that they're going for a degree as a stepping stone, not really to stay there.
Well, I think that's true with our students, and I think it's a great area to explore more. One of the things we found with our graduates is our graduates' average salary is the highest of any of the schools at NYU. And so I don't know how much, and we didn't explore this at all, although we have salary information. I don't know how much that affects people.
Oh, I think
Yeah.
I think it has a tremendous.
I mean, if you look at retention, retention's not related to their salaries particularly. It's a lot of other things. So even if you give them another $5,000.
No, but I think it's starting to have the drawer.
Yes.
You have a starting
And I wonder
salary.
how much of that is going on.
Some students, especially during when you were talking about the economic downturn, would actually say that it was the fact that jobs in nursing were still available and the salaries were high. And I had a lot of second career people, including the stockbroker, come in and say, well, I don't really think I like nursing, but I think this is a good place to be. But one of the problems we have with the salary level, I think the starting salary, now you're going to be shocked when I say this. You all know I come from a background of labor relations, economic and general welfare with ANA and NYS. So, I think we're putting too much money into the starting salaries of nursing. And we have in nursing what's called wage compression.
Right.
Where for the first few years, we're ahead of everybody else, including engineers and CPAs and all of those other solid things. And after 10 years, we're behind all of those. And that's the reason that people leave later on, is their salary doesn't go up.
Or they become nurse practitioners or become nurse managers.
Nurse practitioners, a lot of them do not earn a lot more money than staff nurses unless they go into private practices. So our wage compression problem is a major problem in nursing. I would rather see them stop putting more money every year into the starting salaries and putting it on the top for the nurses who have the more experience, the credentials, all of that.
Yeah, I think that's a big issue.
I think what you said, I just wanted to comment because I do a lot of interviews of the new grads who are coming in, applying for the jobs. We have a lot coming in, and most all of them say when you ask for the short-term, longer-term goals, are looking for going back for education as nurse practitioners, and it's not even for masters or other programs, you know, when we explore that. So that's interesting that comes out on the right way.
What I can never figure out is what's New York based and what's national. I spent 2 years working at the Agency for Healthcare Research and Policy, and, you know, early in some meeting, I said, you know, well, in New York, because that's the kiss of death, say that. And they said, somebody higher up to me said, you know, actually nobody cares what goes on in New York. And they said, because New York healthcare is really different than healthcare in the rest of the country. And so it's hard. On the other hand, since I work at NYU, I mostly care about what's going on in New York. But they do want to be nurse practitioners.
When you explained the associate degree, when you were talking about the difference before, was that regional in any way when you looked at the evidence? Because I know in our area, for those coming into hospitals, if they have the associate degrees, there's less opportunities, and many organizations here will only hire nurses with the bachelor's
You know,
degree.
we didn't look at that. And one of the other things I want to say is that we have prepared a public data set, which will be available at whatever the group is at the University of Michigan that manages all of that. It's de-identified so that if there was a man home health nurse in a small county in South, you wouldn't be able to identify him. So we love it a lot if you could use those data. And if you are interested where you feel it's important that you have identifiers, you can contact me directly and we can make some kind of arrangement with checking with all the IRBs in the world to use the data that's identifiable. The public data set should be out in about another 2 months.
That's fantastic.
And so that's what we asked. We had everybody's zip code. We turned that into regions, and so we could answer that question.
That's great. We offer a secondary analysis course.
Are you
So
doing?
yeah, and teach how to get at whatever we can get at. And we're trying to get more opportunities to use and to find, since now people are at least recognizing that secondary analysis is not only viable, it's a way to get at something as best you can.
I just want to make a point on something that you mentioned kind of earlier on about poor management and injuries, and that perhaps that wasn't one of the things that were linked. But in another study that I participated, it was amazing when the findings that first that there were nurses reporting not having the ability to obtain safe lift equipment, but more so that they had safe lift equipment and they didn't use it. And we saw both of those being reported in that study. And so we didn't look at injuries, so we didn't get any information about injuries. But, part of why are there nurses that are not using equipment that's available, and is that having to do with the management?
And we didn't look into how they got injured. But I think that's another. One piece of information that in an unrelated study I was doing with Jack Needleman, we got is that any person who works in an organization has the right to see all of the data on work-related injuries, and that they have to keep those data. And a potential way of dealing with that is if you can find different people among your students or your friends who work at different places, you can get each of them to get those reported injury data. Nurses have, I think, in the top 2 or 3 highest injuries of any occupation. I think that'd be
lumberjacks and there's one other. I forget what the second one is, but
it's very high.
Yeah, garnishment.
I think that would be a great study to do and to use those data. Now, not all injuries get reported, work-related injuries get reported, but on the other hand, it's also, I think one could argue, a very valid measure of injuries. And finding out, we did in our last survey, we asked them how many days they missed work because of the work-related injury. And I think Amy's looking at that.
The other
Lois,
thing when you're looking at
do your what I love what you've been trying to showcase is that the workers' comp and the related financing is not there for nurses.
one of the things, and I just shut me up if I talk too much because this is one of my big subjects, but with injuries, there's a whole lot of things and shades and nuances. Yes, nurses definitely are up there with the third, but we're much lower down for when it comes to fatal injuries. And so things like
Thank God.
police
That's
and
encouraging.
whatever. But we're still pretty high for fatal injuries. But
Likely to get hurt.
no, but we're still pretty high for fatal injuries, but not like, other ones. But for serious, and there's the different levels of injuries, how they're defined. But one of the problems, and it's related to it has multiple causes. We know there are different kinds of hospitals out there. There are community hospitals, and then there are hospitals that are reimbursed by governments, whether it's state, federal, or county governments and all. Well, in situations where they are government-supported hospitals, I've been working, and I've written to Pam Cipriano, who's interested, and I haven't heard much from the APNA people yet. But where I feel, after doing a lot of studies with nurses who have been injured and seriously injured, some of them have lost their homes. They couldn't pay their mortgage because the disability they get is so much lower than their salary and what they predicated buying their houses on and things like that. So I didn't, and it's a good thing, qualitative research. I always do quantitative. I'm a quantitative person. But at the end of my survey, after all these things, I said, after your serious injuries, and I had the questions and the Likert scales, did you have flashbacks, nightmares, or job satisfaction, this whole thing. And then I put a narrative on the bottom, and I said, please let this researcher know if you think anything was missed in the questions above that may have affected you after your injuries. And I heard back from more nurses than I would have expected that they had major financial reverses. And
Have you written that up?
And yes, I have. Thank you. But I really want to do more on it. So
It's a great.
I got to get going.
Good
But
area
it's
to
important.
explore.
But anyway, what happens if we look, and see, all municipalities are different. I've looked at Boston, I've looked at Chicago and New York City. Police, firemen, and EMTs in almost every municipality, when they are injured by a client, in addition to the regular disability, receive support from that government that almost makes up to a regular salary. Nurses get nothing. So I see that as inequitable treatment of service.
I think that's been brought up with the legislature in New York for the public hospitals, because I agree with you. So if a fireman, first of all, can retire after 20 years, but if you're working in a public hospital,
they call it taxing employee.
and if you get injured at work,
Right.
you get a good amount of money.
Right.
And that's not true for other kinds of workers who work for government.
I can speak for the city hospital because
Okay.
currently I'm out of work on disability because I was injured in psych by a patient.
Oh,
And you have up until 18 months to stay up. So my 18th month is this month. And they have given me my income.
for 18 months.
Yeah, they have.
But what about
But
after
I have
that?
to show proof. I have to go to therapy. I have to have the doctor send in a note, and it has to be in a timely fashion in order for me to qualify for my payroll.
But what happens after that?
What happens after that? Well, right now I have to go back to court for a settlement, and I have to speak to the lawyer to find out if my doctor asked me, you really want to close off your disability case, because I have a lot of injuries in my knees and in my wrist. And it's, if I don't do surgery, if I choose not to do surgery, that injury stays there. So if I close the case. So that is what I have to investigate now with the lawyers. What will happen after that?
But basically, you're on your own, and that wouldn't be true if you're a policeman.
Right. And they do give you, but what they do to sometimes, they give you work accommodation. They have that option as well. So I have applied for work accommodation so that you can give you a job that's less, that you can function at.
But that's
So
still only
it's
covered
still-
by the governmental hospitals.
Right.
More than, I think it's 78 or whatever percentage of hospitals are not government supported. So what do we do about those? I'm trying to see if
And that's the city hospital in New York. We don't know what
Yeah,
happens
but
in the city hospital in St. Louis.
No, as I said, I looked at Boston and Chicago, I think. But then there are all those other hospitals, and what I would like to do is convince management in those hospitals, working through with associations and all, to have insurance policies that would be what that would cover for serious injury. But I'm just trying, and this is what, so you're all from Molloy, you better vote for me when I'm going for my sabbatical, because this is what I want to work on for my sabbatical. But I really think it's so unfair, and I had no idea. I've been working on violence in psychiatry for 22 years. And I'm still working on it because new facets keep coming up with it. And it's the same all over the world, because now I'm working with that whole European contingent. And it's just amazing how many nurses are seriously injured.
I want to ask Eileen if she'll tell you too. I alluded to it, but this is really relevant in terms of stress on the job. She's done some multi-year, not the same people. It's not longitudinal, it's cross-sectional. But I want to talk about the difference between the 2013 grads and the 2014 group.
We did look at the stress level over the years in those three groups or three cohorts, and the stress level increased. So I was trying to look at the years that it was between 2013 and 2015 that we looked at. And
was this among the students or in their
It was
first
an
job?
SNA sample of a couple thousand.
Right, it was the national sample of those nurses who were in acute care environments for a period of a year, and then they were asked survey questions in relation to their stress. So as we coded the stress level, it increased through those years, and we were trying to look to see what was occurring in the work environment within those periods. And I know coming from that, I was very interested in healthcare reform, and when the Affordable Care Act, most of those provisions hit in 2014, and as those increases, the pace of the workflow, the whole readmission and the reimbursement components, and would that have been, because I looked at pace of workflow as one of the stressors, and it was interesting what you found in regards to that, as well as the other interpersonal several other things that you looked at as well. But I know we are always hearing from our new grads as well as our experienced nurses the pace of what they need to do and get accomplished in a short period of time seems to be a big stressor.
That sounds like a fabulous area to keep exploring.
I think they look at the relationship with patient satisfaction, because I think that's adding so much to the stress, because more and more so, because I still work staff, so so I can speak from that end too. So more and more you're being held to keeping the patient satisfied, and sometimes it's there's some conflicts in terms of, well, no, you shouldn't be smoking, but, they don't feel satisfied. They don't feel or that your kid doesn't need antibiotics because it's a viral infection, right? And then they walk out and they're annoyed because they didn't come out with a prescription for antibiotics. So that, I think, I did a focus group over the summer, and one of the things that very much came out was this attention to patient satisfaction. And this is, I believe, adding a lot of stress to nurses at the bedside.
Well, I think that's a fabulous point that, which I had not thought about, is the nurses being held accountable for.
Yes, because if there is a complaint, you hear about it, right?
And it depends on the institution that you're working at, whether you're supported or not. It's very interesting.
And it's that balance with the rapid discharge and the patient and family's perspective that you're pushing them out earlier than they should be, and can you get all of those things done in the education?
Right.
It seems like a rush very often.
And sometimes even the opposite, like when there's things you cannot control for. Okay, well, your baby, I work in the neonatal unit, so your baby can't go home because we have to get this test done. Oh, Friday, it's 5 o'clock, and sorry, it's not going to get done again until Monday, and now baby's going to be here the weekend, and now it was really nothing that you could do anything about, because I can't control radiology or the other departments, but I'm the person at the bedside, and I'm the person that they're talking to.
Right, you're the mean one.
And you're the one they might really yell and scream at.
Yell and scream at, and that's part of it too, because I don't know how well, I think that's one of the things that I see just from where I work and the newer people, is that sometimes that just throws them, because it's just not a lot in their experience of people talking to them like that. So I think some of the new people have more problem with that.
Well, one of the things in with my findings was the communication. We looked at interpersonal, that domain, and the nurses in the higher age groups seemed to do better with those communications. It was more stressful for the younger nurses, those coming right out, to interact, like with patients, families, whether it was other domains or groups.
I would see that would happen.
I just have 2 questions. I'm not sure if the study really delved into the why of things, but 2 points that you made. One of them was that the MD nurse relationships satisfaction had increased. Any idea of why?
Yeah, I mean, one of the downsides of doing a project like this is that we didn't delve in detail into the background, and I think some of these questions are probably best answered by some kind of qualitative approach.
Yeah.
Anyway, so the answer is no.
Right.
And we didn't do any. It's always a question of what's going to be the dependent variable.
Yeah.
And we didn't do physician nurse getting along as a dependent variable. But that's those kind of questions could be answered with our data. We just haven't done it.
And we had to communicate with physician item, right? And our communication with physicians, I think, was an item. We didn't analyze each of the items, but we have it in the data, so we could probably use that. So.
And I'm curious if the relationships are different between teaching versus non-teaching hospitals as
We
well.
didn't do that analysis.
Yeah.
It's so we have so much data, and it's so overwhelming. I feel badly, like we didn't do that.
No, don't feel bad.
But there's just so much.
So to that end, and it's much less emotionally charged than everything else, was it from the foundation or from the research group that came up to disseminate the data through the Inter-University Consortium for Social and Political Research? So that's the ICPSR and the UMISH. Is it like with the NIH where they make you upload the genomic data within a month, or was it your idea? Because I think it's great.
One is in the original grant, the foundation said we had to do it. But second, what's going on at NYU, partly because we have so much NIH funding and we have to share our data, is and that somehow has gotten to the library people, and they are going around helping people how to do it and pushing people, even if it's not NIH, that they have to share their data. And they're preparing, we have a website, which I think may become publicly accessible. The library is working on this, where they're listing all the data that people have around the university, so that if I wanted to use your data, I could get your name and call you and find out about it. So it's a very high priority for NYU.
That's great. I agree. So you gave them only the limited data set for public use? Did you give them the back file where you can go in and ask for secondary as a researcher through UMISH? Because that's the other way. When I got my twin data through ICPSR from a study that was done on the Ad Health data set, they have it up at ICPSR. I needed twin data because it was causal modeling. And I could then write and ask for the identified data as a limited data set, so people don't have to go through you every time they want it.
No, they wanted to do that.
And you said no.
And we said no.
You want to own it.
Well, not so much we want to own it. We felt like it wasn't fair to the people who participated.
Because they didn't know it was going to happen.
Yeah,
like
to have, data. And the guy on the phone was, I'm totally reliable. We won't do that unless there's, we have an IRB approved thing or whatever. And we discussed it as a group, and we just said no to that.
Because it wasn't in the original consent.
Extremely annoyed that we didn't do that.
Right, they did try and push you for that one.
And I said people can call us, but no, this is all that's publicly available.
Let me make sure our guest student gets an answer, gets a question.
I'm almost intimidated to ask a question, to be quite honest with you. I wanted to know, did your study focus at all with new nurses going into specialty areas and turnover rates? Because that's what I really am interested in my dissertation. I want to look at nurses and that do not go into medical surgical nursing for the first year when you were speaking about that, and instead choose a specialty area like maternal child and job satisfaction, and if they continue their education, because I am a product of that, and I'd like to look at that and see.
We didn't look at that, but we know what job they had.
So do they stay there? or do they go into other fields?
There's some flaws in the data, and so if they did something, because we surveyed them every 1 to 2 years, but if there was some change within that time period, and then they changed twice, say, we don't have information about that middle job.
Okay.
And we asked them for that, but that data is just not very good. On the other hand, we do know for most of them what unit they were on, what kind of unit they were on in their first job, and what kind of unit they were on in their job a year later.
Okay.
So it's not perfectly what you want, but
Okay.
it's
Well,
you could put together something, but I wouldn't.
I work full-time in a different college, but I'm doing my doctoral studies, my student residency, my practicing here. And we find that a lot of the senior nursing students, they have their capstones in specialty areas. And I'm finding that when they go into specialty areas, then they follow that track. And they go and they stay in the specialty area. So that's really where my interest came from.
You could do it a little, but I'm happy, by the way, to send you a code book. You send me an email, and then you can see what variables we have.
Okay.
I think that's a great question. We didn't ask that.
I want to introduce you to Gloria,
I'm
Dr.
Gloria.
O2. Gloria's in that corner over there.
Hi, I'm Francine.
And her dissertation, in fact, has new graduates' plans to go into specialty areas, and so she's somebody you can talk to.
Wonderful,
about that.
thank you so much.
And how many didn't? No, you only have the graduating seniors.
Yes.
In fact, so that's who she has. So you'd have that front end part.
That would be wonderful.
I want to try and get this. This is great, but I want to make sure that we get everybody out so nobody feels like they had to leave and didn't want to leave. So I want to make sure we all thank Dr. Kovner for being
My
here.
pleasure.
And if you have any follow-up burning questions, please feel free to stop by and ask her. I did give you some time to put her email down, but you can also find it from me, and she's giving me the without pics. So we also have recorded this. I'm going to stop that and stop talking.